and welcome once again to the UCLA Center for Health Policy Research's Health Policy Seminar Series. My name is Gwen Driscoll. I'm the Director of Communications here. I'm delighted to welcome you and also to encourage you to check our website, www.healthpolicy.ucla.edu, for news and announcement about upcoming seminars. You can also sign up for our e-newsletter there, Health Policy News, which will give you all the latest updates on seminars as well as our data and research. And now, without further ado, I would like to introduce our speaker. Dr. Elisa Long is an assistant professor in decisions, operations, and technology management at UCLA's Anderson School of Management. She's also a former faculty member at the Yale School of Management. She has worked Professor Long's research interests include healthcare operations management, policy modeling, simulation, and cost-effectiveness analysis of medical technologies. She has worked nationally and internationally on epidemiological modeling, economic analysis, and crisis decision-making, with the goal of assessing the value of health interventions and assisting policymakers with allocating limited resources most effectively. Among her many research projects, Dr. Long studies intensive care unit bed utilization, which is the topic of her talk today. So please help me welcome Dr. Elisa Long.
Thank you, Gwen, for that kind introduction, and thank you so much for inviting me here today to speak. It's wonderful to get to this end of campus, which I don't get down here as often as I'd like. So today I'm going to tell you about some ongoing work that I'm doing with a critical care physician, Kasum Matthews. When we started this study, we were both at Yale. She was in the School of Medicine and I was in the School of Management, and we've now subsequently both relocated. So I've joined UCLA just this past fall, and she is now at Mount Sinai. And from the perspective of this study, this is a great thing because we're now hoping to replicate this study using data for our two other institutions where we currently are. I should also say, please feel free to stop me along the way if you have any questions or clarification. We will have some time at the end for questions also. So today I'm going to be talking about an econometric model of waiting in the intensive care unit. And as I think most of us in this audience know, healthcare costs in the United States have been growing pretty dramatically over the last 50 years. And this chart shows the breakdown. And the line that I really want to point out is the black line at the top, which is hospital care expenditures. So this is really the largest component of all healthcare spending in the United States. And what you may not have realized is about 14% of this, or over $100 billion per year, is spent just in the intensive care unit. So we're talking about a huge amount of money being spent to care for these individuals. And the patients who receive care in the ICU are particularly vulnerable. They're the most critically ill patients, often in the hospital. About 5 million patients are admitted annually in the United States. And this is projected to increase substantially as the population over age 65 is projected to increase by about 50% between the years 2000 and 2020. We've seen a lot of hospital consolidation in recent years, despite an increase in demand in ICU for ICU beds in the earlier part of this decade. And many hospitals report high bed occupancy levels, ranging from about 70% all the way up to 100%. Many hospitals actually report operating above 100% utilization. And of course, this can cause frequent delays in ICU admission. And one of the goals that I'm interested in looking at is, how does this delay in ICU admission impact patient outcomes? As I mentioned, these patients do tend to be much more vulnerable. They're often elderly, and they have the highest mortality rate in the hospital. Up to about 30% of these patients end up dying. And this map shows kind of the variability in ICU bed availability around the US. So this is from a 2010 study in JAMA. And I just want to point out that the dark red is 4 beds per 10,000 people, and the light yellow is less than 1 bed per 10,000 people. So we have mass variation within the United States. In Los Angeles, we're sort of kind of in the middle of the pack for bed availability. But I think moving forward, this is going to become an even bigger concern again as more people require ICU care. Okay, so within the hospital, there are, of course, many individual intensive care units. The focus of my talk today is just going to be on the MICU, or the Medicine Intensive Care Unit. This is often the largest ICU, but of course there are other ones such as surgical, neurosurgical, and so on. And think of the ICU as one kind of stop on a visit through the hospital. So patients typically enter the ICU from another part of the hospital, and then they leave the ICU and go to another floor or ward within the hospital. So they typically don't come, it's not like the emergency department where they're coming from home, they're typically coming from some other part of the hospital. And we can think about different, sometimes competing objectives that the hospital and patient may have. So I've just listed a handful of these to give you a sense of the type of outcomes that I'm interested in measuring. On the left, we have operational metrics. So these are things that the hospital administration might be interested in capturing, such as bed wait times, utilization levels, again, the percentage of time that an ICU bed is full, different nurse or doctor staffing levels, how long they spend in the ICU. An ICU bounce back is when a patient leaves the ICU but then returns, often on that same hospital visit. And transfer times are, again, the time spent between one ICU bed and another part of the hospital. On the patient outcome side, of course, patients are interested, as are their caregivers, in survival. The goals of care typically refer to if the patient is being treated for either resuscitative or palliative care. Infection risk is something I'll talk a little bit about later, but this is something that a lot of hospitals are both keeping track of and has been shown to strongly correlate with length of stay in the ICU. The comfort and pain level is, of course, concerned. Functional status and location of hospital disposition. This refers to where patients often go once they actually leave the hospital, whether it's a skilled nursing facility or home, and so on. And so my research is broadly interested in trying to link these operational metrics with patient outcomes. So can we look at how factors of a patient's stay that don't really have anything to do with them clinically, but more kind of operational byproducts of their visit, what effect does that have on key patient outcomes? Okay, so the setting I'm going to be talking about today is Yale New Haven Hospital. Just to give you a little bit of background and context, following a recent merger, they're now actually the 4th largest hospital in the US. And they have an average of about 23,000 medicine service admissions per year, so a really large facility. Basically, if you get sick somewhere between New York and Boston, this is the hospital you go to. And in 2010, they expanded into a new unit and really increased their capacity of their medical intensive care unit. So the ICU currently consists of 51 beds, and this is broken down. There's basically 2 types of beds. There's what I'm calling an ICU bed and an SDU bed, or step-down unit. This is sometimes also called an intermediate care unit. And the physical layout of the beds is very similar. So these pictures are from the hospital at Yale New Haven. I think this is a dialysis machine on the top photo. And so the physical layouts of the ICU and the step-down unit are similar. The main difference is the staffing ratio. So in the ICU, the ratio is 1 nurse for every 2 patients. In the step-down unit, it's 1 nurse for every 3 patients. And if you compare this with the general floor in the hospital, the ratio there is typically 1 to 6 or 1 to 8 patient to nurses. So we're talking about a very intensive setting. Additionally, the other difference is the physician on call. So in the ICU, they always have an intensivist or a physician who's board certified in critical care medicine, whereas in the step-down unit, these can be staffed by general internal medicine or internists. And to give you kind of a sense of it, think of the estimated cost that we got to expand or to build an extra one of these beds is about $1 million per bed. So they're hugely expensive. They have a lot of technology available. I think at Ronald Reagan, the average, I think our NICU is around 20 or 24 beds or so from what I've heard. So they're obviously very expensive. And when we're thinking about expanding capacity, we really want to think about balancing these trade-offs of both the kind of fixed cost of building extra beds and staffing them with the perceived benefits of doing so. Okay, so the motivation for this particular study was in conversations that I had with my critical care colleague and her colleagues. And it was this observation that patients were spending a long time following the receipt of their care in the ICU, but waiting for transfer to another part of the hospital. So to kind of give you some idea of the length of stay or numbers on these, these are average numbers kind of the flow through the ICU. So on average, a patient's physician requests an ICU bed, and they wait about 1.8 hours before they actually are physically assigned an ICU bed. Then they receive service, which we're calling the service time, on average for about 2.7 days. And then following that, their physician books them for transfer. So this is a signal that they're finished with their critical care intervention, assuming that they survive. And then they'll be transferred to another bed in the hospital. And this is what we're denoting as the non-service time. So the average non-service time at Yale New Haven is about 12 hours. And this distribution at the top shows you the histogram of these non-service times. So the average is 12 hours, the median is about 6. There are a few people who wait several days in kind of this transitionary period. And we were really interested in this because, as far as we know, no other study has actually tried to measure this particular timestamp, but the granularity of our data has allowed us to kind of separate the length of stay into these two components. And there's kind of two things that are happening here. Number one, this non-service time is potentially bad for the patient. So the longer that a patient is in the ICU, waiting for transfer, potentially the worse the outcomes are. So during this time, think of it as if a patient has something like a central line or a urinary catheter in place. All of those things are going to remain in place during this non-service time. And it's been established in other studies that the longer those things are in place, the higher the risk of severe infection. Like a central line infection would be a pretty catastrophic infection for a patient to have. Secondly, there's this externality to the other patients. So when a patient is sitting in a bed but not actually requiring care, they're causing excessive wait times for other patients. So we wanted kind of to study, to look at what are some of the drivers of this non-service time, and then secondly, what impact does having this non-service time on wait time eventually have on patient outcomes. So this is kind of the motivation, at least empirically, for the study. So I'll pause here for a moment. Are there any questions so far? Yes.
So are those the non-service time? Is it usually reimbursed?
So I've heard not at the same level that the service time is, that they're occupying a bed. So keep in mind that if a patient is sitting here and something bad happens, they're not going to just ignore the patient and say, oh, you're done with your service. So of course they might re-enter service, but no, it's not being reimbursed at the same rate as the active service time is. And that's actually another good point. If you look at the reimbursement by day in the ICU, the first day is reimbursed at a much higher rate than any subsequent day, because that's often when a lot of interventions are happening or diagnostic tests and so on. So you sort of see this drop off later during their stay. Yeah, that's a good question. Any other questions?
So my question
Sure.
is, on the non-service time, how does the step-down unit fit into this?
So
You may have said it on a previous
no,
slide.
I didn't say that. So that's a good question. So I should actually kind of clarify that this is the second motivation for this study. So what the step-down unit is intended to be is exactly what it sounds like. A patient starts in the ICU and they step down or move down to this kind of intermediate care unit, and then they eventually move to the floor. Practically speaking, what's happening at a lot of hospitals is the step-down unit is chronically full. It's always full. So then you get these patients who are sort of intermediate care. We call them subacute patients who are actually in the ICU requiring more nursing and more physician levels when they should actually be in the step-down unit. So this is kind of some ongoing work that we're looking at, which is what's the optimal split. So when I mentioned 36 and 15, there is absolutely no rationale for how they picked those numbers. And our data is suggesting that they should actually probably shift to more step-down units, or at least dynamically think about shifting. Any other questions? Yes.
Mark, just repeat the questions as they come up so we can hear them.
Oh, sure thing. You want me to? Well, I'll do. Moving forward. Thank you. Yeah, no problem. Okay, so the overall objective, we have two objectives in this study. The first is using data for our institution is to empirically measure the impact of census levels or crowdedness in the ICU and on the floors on length of stay. And secondly, the effect on readmissions. And we have three hypotheses that we're going to test. The first is that a higher ICU census level, meaning there are more patients in the ICU, this is going to result in a shorter length of stay for those patients as the ICU staff potentially try to free up a bed. And we're calling this a speed up of care. The second related hypothesis is kind of the flip of that, which is a higher medicine floor census. So again, the medicine floor is where patients go to following their stay in the ICU. We would expect that a higher census there actually leads to a longer length of stay as the floor staff try to delay some of these transfers from the ICU. So we're calling this a slowdown of service in the ICU. And then the third hypothesis is we might expect that if length of stay is sped up due to a higher census level, we might be doing this at the cost of readmission. So we might expect that if patients are getting inferior care because the ICU is really crowded, their chance of getting readmitted within 30 days is going to be higher. So that's going to be our third hypothesis that we test. And then the second half of this study I'm going to present today is we then want to actually estimate the impact of waiting for an ICU bed on in-hospital mortality. And this, it turns out this is a little bit harder question to answer than we thought, so we'll talk about that in a minute. But the hypothesis we want to test is that the longer you wait for an ICU bed, the higher your chance of dying, because you start to clinically deteriorate while you're waiting for a bed. Okay, so I'm not going to go into a lot of detail about the related literature, but I'll just highlight a few key studies. So there's been, in the medical literature, there's been a number of recent studies in the last few years that have tried to look at the impact of ICU admissions on patient outcomes. So one paper by Stelfax, which was a little bit disconcerting, found that when patients arrive to an ICU and there are no available beds, they're more likely to get comfort care or palliative care than resuscitative care. Which is an interesting finding in and of itself. The next study by Cardoza, this was done in a Brazilian hospital, and they actually tried to do something similar to what we're doing, which is estimate the impact of waiting on the risk of mortality, and they find a 1.5% increased risk of death per hour of delay. Now, Brazil is a little bit different than the United States. So in talking to my clinical colleagues, for example, they don't have these things called rapid response teams. So in the emergency department, for example, if you come into the ED and you're waiting to get admitted to the ICU and you start to decompensate, in the US, they'll often send out these rapid response teams to intervene, whereas in Brazil, they typically don't have that. And this was also based on a really small sample. And then Chalfin also found a similar effect, that as you increase, as you go from having a less than 6 hour delay to a more than 6 hour delay, the chance of dying goes up from 8% to 10.7%. So there's been a few studies that have looked at this, but by and large, we haven't seen in the US setting the kind of the question that we're interested in, which is sort of what is a patient's kind of elasticity to waiting in terms of their mortality. Then in the operations literature, which is sort of where I come from, there's been a number of papers that have looked at queuing and different simulation models. So I'll talk a little bit about this towards the end, but we're actually doing a number of ongoing studies where we look at different bed allocation policies or triage policies to see if we can kind of optimize the policy for who should get that last remaining bed in the ICU. And then lastly, there's been a couple of kind of more econometric models. This has been, I think, as more and more data have come out of hospitals, I think more studies like this have been done, but a couple of them that I want to just point out are some studies have tried to estimate just what is the benefit of ICU admission period. So not the impact of waiting, but just how much better off are you just getting admitted to the ICU. Of course, there's some concerns with endogeneity and other, who gets admitted to the ICU depends on a number of other factors, but there is a stream of literature that has tried to estimate that. Okay, so let me tell you a little bit about our data set. So we were able to collect, before we left Yale, actually, we were able to collect a pretty rich patient-level data set. So I'll talk about kind of on the bottom first. So we collected data for about 12 months, all patients who are admitted into the medicine ICU at Yale, and we included in this data timestamps throughout their hospital stay. So we actually are able to measure when their physician requested a bed, when they actually began service, when they completed it, when they requested a transfer, and so on, as well as where they were discharged to, if they survived or not, where they originated from in the hospital, so either the emergency department or the floor, their acuity level, whether or not they were readmitted within 30 days. And then we have a number of other patient factors. So we have age, insurance status, and the primary DRG code for this stay in the ICU. And so in addition to kind of this patient level data, we also have census levels over most of the 12, or over about 9 months of the study period. And interestingly, unlike a lot of hospitals, they actually collect census 4 times per day. So many hospitals only collect census at midnight. The challenge is, of course, by the middle of the day, the census may have changed substantially. So we're lucky that we were able to get census levels more frequently. I think now there's actually a push to collecting census levels every hour, which will be even better. But these graphs give you, these are just the raw numbers. So this just gives you a sense of kind of how much variability there was in the ICU census, which is, again, in the NICU, out of the 51 beds, and the medicine floor census. So this is an aggregate measure of just how many patients are on the medical floor. So you can see the average for the floor is around, I think, 375 or so. And for the ICU, I think it's around 45 patients or so. Okay, so these are just some of our summary statistics. So before I get to kind of the regression results, the dependent variables that I'm going to be talking about initially are, again, total length of stay in the ICU, which we're breaking into a service and a non-service component, as well as a binary variable for whether or not the patient was readmitted within 30 days to the hospital or not. And about 30% of our patients are readmitted. For the independent variables, as I just mentioned, we have these 2 census levels. So we have the census within the ICU at the time the patient is booked for transfer, and then the floor census levels, which is, again, on the floor in the wards, and these are our average levels. So about 356 for medical census and 46 for ICU census. Our average age patient is about 61 years. We have, again, the DRGs, which we coded as dummy variables. About half of our patients originate in the emergency department before coming to the ICU. Then we have a breakdown of Medicaid, Medicare, and the third omitted variable is just private insurance. One thing to note, which I didn't realize is going into this, is that patients who come into, in this setting, patients who come into the ICU who are uninsured, typically while they're in their stay at the ICU, they get enrolled in Medicaid. I don't know if this is a Connecticut thing or if this also happens in California with Medi-Cal, but most of our patients then are coded as having some type of insurance, but this does include those patients who maybe started their visit uninsured and then ended up at least partially insured by Medicaid. We have weekdays are Monday through Friday, and then the nursing shift is from 7 to 7, and so we wanted to code for whether or not a patient left or arrived during the day. So we, instead of doing it hour by hour. Okay. So the first set of results I'm going to present is just looking at overall length of stay. So this is actually similar to one of the other papers by Casey and Turwich, that the kind of the punchline of their paper was yes, we see as the ICU gets busier, people move through there faster. So again, we should think of this as my dependent variable here is length of stay, total length of stay in the ICU, which I'm logging, so we can interpret these as percentages. So again, think of this as for each additional patient in the ICU, a patient's length of stay goes down by 3%, which is, and it's very significant, it's a huge effect. So we are seeing this kind of speed up of care, and we see sort of the reverse with the medical census. So we see the slowdown of care. So as the floor gets busier and busier, we see patients in the ICU end up having a little bit of a longer length of stay. So this is relatively consistent, at least the first coefficient, with what other studies have shown. We were a little bit surprised by a few of the insurance coefficients. So I'm not going to talk about this a lot, but I'll just point out that Medicaid was very significant. So Medicaid patients had a shorter length of stay than the third kind of private insurance category after controlling for age and DRG code and so on. You know, I think we could interpret that as we like. That it's possible that the hospital is getting less of a reimbursement for Medicaid. I'll be sort of agnostic on that one, but we were a little bit surprised to see that those were significant after all. Okay, so this is kind of our base model, but then what we really wanted to test was, okay, so we see this speed up of care and total length of stay But when we split it into these two components of service and non-service, where does it actually manifest? And when we do that, what's interesting is that we find that the service time is not actually affected by census levels. All of the effect is in the non-service time. It's in that 12-hour kind of buffer or waiting time where they finish their care, they're waiting for transfer to the ICU, and we see an even stronger coefficient. So again, for each additional patient in the ICU, the non-service time decreases by about 8%. So we can think about this as, at the mean, that amounts to about 1 hour shorter time. So it's sort of like when push comes to shove, when the ICU staff really need a bed, they're able to usher people out in time and reduce that non-service time. And we see the reverse again with the med census. We have a positive coefficient. So as the floor gets fuller and fuller and fuller, they actually start delaying transfers coming in from the ICU. They instead prioritize patients from the emergency department. So that means that these patients are sitting in the ICU, occupying a bed, causing, again, further downstream delays to other patients. That's kind of the explanation that I think is most consistent with this. So these are kind of, we can think of these as sort of average or linear effects, but we really wanted to know, does this coefficient hold across all census levels? So maybe it's really only when the census gets really full do we start to see a speed up of care. So what we decided to do is to break the census into 10 deciles and look at the coefficients for each particular decile. And what we find is exactly what we would have predicted, which is as the ICU gets fuller and fuller and fuller, so really in the 9th or 10th decile, so this means all 50 or 51 beds in the ICU are full, we see this massive speed up of care. When they really need, when there's only one bed available, let's say, or no beds available, they're able to get people turned around quite quickly. But what we thought was kind of interesting is on the medicine census, they actually start this speed up much earlier than they probably need to. So again, the medicine floor has something like 400 beds. This is saying when only 300 of those beds are full, we start kind of delaying transfers coming in from the ICU, which is, from a hospital's perspective, a really bad policy, because letting those patients sit in the ICU while they're tying up a bed, they're not getting reimbursed at the full amount, they're causing a delay to other patients. And keep in mind, this is an entire kind of system. So when you delay patients leaving the ICU, you delay patients coming in from the emergency department, which then causes their own delays in the ED. So it's this hugely connected system. So if there is one punchline that I would tell the hospital manager at, or the bed kind of allocator at Yale, it would be have better coordination across the floor, and don't delay patients coming in from the ICU this early. You could wait actually until the floor gets really, really full. I think this is also partially explained by the fact that the floor is really decentralized. So the ICU, this is one kind of coherent unit. It's the same doctors and nurses staff all of the beds in the ICU. On the floor, we have 400 beds, and these are scattered across a variety of services. So we have oncology, we have cardiology, we have obstetrics, and so on. And so they're not all coordinating with each other either. So one of the things that we're actually exploring is, could we actually sort of pool some of these beds and have beds that can service different disciplines and kind of create more floater type beds, which would actually help, I think, streamline a lot of the flow from the ICU to the floor. Okay, and then we examined readmissions also, and I guess the good news from a patient's perspective is we didn't see an effect on readmissions at all. That census levels have no significant effect on the probability of being readmitted. Again, this is reassuring from the patient's perspective that you're not getting this inferior care just because the ICU is busier. And I think it's consistent with the fact that they're speeding up the non-service time and not the service time. The non-service is this non-essential kind of transfer time, and so if that gets accelerated a little bit, that actually just makes the system more efficient than if you were actually impacting service time. Okay, so I'll pause here. Are there any questions so far? Yes.
We have one from the internet.
Oh, sure.
Wei Yen is asking, is the non-service time considered observation care in hospital charges?
Is it considered observation care?
Yeah.
So I don't have a perfect answer to that. I'm not a clinician, but my clinical colleague has said that it's not observation care in the sense that they actually, you can have an entire stay in the ICU be just observation care. And so this could include observation care, but it doesn't have to. This is more like a holding period.
Thank you.
Yeah. Yeah. Other question? Yes, and then you missed.
On your previous slide, with the medical census, and maybe I'm wrong, but I think operationally, there's not a central hospital level allocator that it's driven by floor. And so I think that, and I think I agree with your communication on this. But I think that the floor manager who's receiving that bed might be more or less full. So as someone on cardiac unit, and as you want to transfer someone to my floor, I might have 1 or 2 beds. So you might be losing a little bit of nuance of this hospital wide. And if you know where they're going, you get their census. I think that might be.
Yeah, I 100% agree with you. I'll repeat the question. So the question or the comment was about the floor census being really decentralized, and there's not necessarily one planner who's allocating these different beds. So I completely agree with you. And I think from an operational standpoint, I mean, in queuing theory, we use this term pooling to refer to this notion of, rather than have 10 separate units where patients, it's like when you go to the grocery store, right? Rather than have 10 different lines and each person waits in a separate line, it's much more efficient to have one line and you go to the first available checkout counter. So the question is it clinically feasible to do that in a hospital setting? And I don't have the answer to that. I think some of these beds are very specialized. If you, for example, in the renal, I guess, ward, if they need dialysis machines in every bed, that it doesn't make sense to have all 400 beds have a dialysis machine. We should have some specialized beds. But I think a lot of these beds, in conversations I've had, are relatively similar to each other, but we partition them into these wards sort of artificially. Unfortunately, we don't have individual unit level census data. I wish I had that, the way that I have med census. I just don't have those numbers. Was there another? Oh, Inez, and then yes.
I was just curious if you did any interactions with, say, Medicaid and one of your primary regressors.
So that's a good question. We did in the paper, which I'm happy to share. We do interactions of census levels. I didn't interact insurance and census, but I easily could and look at that. Yeah. So I'm not presenting all of the results, yeah. But I should mention that too. We have a paper under review right now, which I'm happy to share also. Yeah. Question.
For the readmission, is that possible? People goes to a couple of hospitals.
Yeah. So I think that could be one explanation. I think the one thing that pushes against that is, again, as I mentioned, these are really sick patients, and unlike, let's say, Boston or New York, where you have a number of critical care hospitals, this is the tertiary care hospital in sort of a 50-mile radius. Unless you go up to Hartford, this is really where patients are going to go if you need a higher level of care. So I don't think we're losing a lot of patients to other hospitals. But yeah, that's a good question. Yep.
So I was wondering, are there any other reasons, apart from the fact that there are specialized beds in the medical, on the medical floor, that would prevent acceptance of patients that are coming back from the ICU? Is it a staffing issue? I mean, what other motivators could there be that you haven't accounted for?
Yeah, so in conversations that my physician colleague has had with the staff members, they say they prioritize ED patients. So there's kind of this culture in a lot of hospitals of we want to kind of reserve capacity in case a patient comes from the ED. Because remember, not all patients go through the ICU. So in fact, I would say only the very, very sickest patients go through the ICU. So a patient, let's say if you had a heart attack or something, might be in the ED and then go to the cardiac ward and not go through the ICU at all. So this general feeling that we've gotten from the staff on the floor is when they sense that they're starting to get full, they want to reserve a couple of beds in case an ED patient comes. But what I don't think they realize is they're doing, the unintended consequences of that is that they're causing this backlog in the ICU, which then still impacts the ED. And so I think unless you can examine the data and kind of point to where this is happening, I don't think that they're aware of it, right? I don't think anybody is deliberately doing it. It's just kind of what's happening through day-to-day operations on the floor. Any other questions? Yeah.
I know you said ICU non-service time is reimbursed at a lower rate than service time, but how does non-service time compare to reimbursement for floor time?
That is a good question. I don't know the answer to that. I can find out. I mean, I suspect that the floor time hugely differs based on the service that you're there, right? So if you're an oncology patient, let's say, that's requiring very intensive and expensive physicians or treatment or something, that's probably going to reimburse much higher, perhaps, than if you're in an infectious disease patient. So I think it probably depends, but I could look at that. I mean, it would be interesting. So we're not actually doing really very much on the reimbursement side, but I think in observing that the Medicaid and Medicare patients have a differential length of stay, again, controlling for age and DRG and so on,
Right.
I suspect that this is certainly driving that.
Yes,
but,
and so you've got to investigate that, because what you're describing right now applies to privately insured patients. It does not apply to Medicare patients who are fee-for-service, because the hospital's receiving a DRG payment. They're not being paid separately for ICU care and time on the floor. They're getting a lump sum payment. So that's a totally different financial incentive. And it would be really interesting for you to explore whether that is accounting for the reduced length of stay in the ICU, because believe me, I mean, DRGs have been in place for 30 years. Hospitals know that they're not being paid more for that patient being in the ICU necessarily, per se.
yeah.
I mean, they may be being paid more because the patient has more complications and comorbidities, and that bumps up the payment. But the length of stay is basically a fixed payment. And depending on what Connecticut is doing, Medicaid may also be using DRGs. I don't know what they do in Connecticut.
Yeah, that's a good comment. So I'll reiterate this, I realized. So the comment was about differential reimbursement between Medicare and Medicaid. And yeah, I think that's absolutely something we'd love to explore. I mean, I'm not an economist, I'm an operations person, so I'd love to talk more with the econ folks, because I more think about kind of operational issues like wait times and readmissions and bounce backs, but I think that there's absolutely things that are driving that. Yeah. Okay. So I'll so move forward. So just to recap, returning to the 3 hypotheses I mentioned at the beginning, we do find support for the first 2 hypotheses, that we see an impact of census levels on length of stay. And again, when we separate length of stay into the service and non-service component, we find that all of the effect is happening on the non-service component, which hasn't previously been examined. The third hypothesis we find no support for, at least in our particular data set. And to give you kind of a punchline before I show you the results, for the fourth hypothesis, we have some support that longer wait times increase the probability of death. And I'm sort of conservative because of the significance. So I'll say we don't have definite proof, but we have some support for that. So let's move now to the last hypothesis. So we found, again, in the first portion of the study, we were really looking at length of stay and what are some of the drivers of length of stay in terms of census level. Now I'm actually kind of going even earlier in the process to the wait time that a patient experiences before they get an ICU bed. Our data set is a little bit bigger because it turns out we didn't have perfect data or timestamps for all 2,200 patients, but we have pretty good data on when they requested a bed and when they actually began service. So we have about 2,200 patients here, and this is a histogram of wait times for over about 12 months of these patients. So you can see the median wait time is about 1.1 hours or so. We actually we did exclude patients who waited more than 12 hours. It's a relatively small percentage of patients, and this is probably either explained by it was miscoded in the data and they actually did get a bed, or they moved to and they no longer actually required an ICU bed, but it didn't get recoded like that in the data. And about 95% of our patients wait less than 6 hours, which is good, again, from a patient's perspective, that they're getting beds, but nonetheless, wait time is still a concern for many patients. So I want to talk about kind of the challenge of trying to estimate this question. So again, we're really interested in trying to figure out what is the impact of waiting on the chance of dying. And if I run, and I'll show you the results for this, if I run just sort of a naive or a basic probit model, I can try to estimate this, but this really suffers from this problem of endogeneity. And that is, in a system like this, imagine it like, the longer a patient waits for an ICU bed, that tends to be the less sick patient, because we're not in a first come, first serve sort of model here. We're in kind of a priority model. So the sickest patients are going to get a bed first. Those who are less sick are going to end up kind of going to the back of the queue. So if we run sort of the naive probit model, what we're going to find is that patients who wait a long time have a lower chance of dying just because they're less sick. And so this really will kind of misestimate the thing that we're interested in, which is looking at what is the actual impact of 1 hour or multiple hours of delay in receiving an ICU bed. So we want to sort of do the thought experiment. Suppose I have 2 patients who are equivalent age, acuity, DRG code, and so on, but one arrives to an empty ICU and gets a bed immediately, and one arrives to a full ICU and has to wait an hour. Do they have a difference in mortality? That's kind of the question that we're interested in. And so in order to examine this, we're going to use a very common technique in econometrics. We're going to use an instrumental variable approach, and we're going to use ICU census as an instrument in this case. So the basic idea is and I know many of you in this room are very familiar with this, but for those of you who aren't, I'll just give you kind of the overview. We want to try to kind of disentangle what is the impact of waiting on mortality, and we're going to use ICU census as kind of this exogenous shock that we know impacts wait time, and we believe impacts mortality no other channel except via the wait time. And again, in this case, the ICU census is not quite the same as it was in the previous studies. This is the census immediately before you arrive to the ICU, whereas previously it was the census when you finished your stay in the ICU. So questions so far about that? Okay, so whenever you're doing an instrumental variable approach, of course, it's important to address some of the concerns about whether or not this is a valid or powerful instrument. So I'll just give you kind of a high-level overview of how we thought about this. So the first, of course, requirement is that we need wait and ICU census to be strongly correlated. If we just run this regression, we get a very, very strong effect. So this is exactly what we would expect. Namely, across all patients, those who arrive to a busier ICU census end up waiting a longer period of time. So we certainly satisfy that requirement. The second requirement, largely is ICU census uncorrelated with some other factors that could impact the mortality probability. So we ran a number of regressions where we look at the relationship between ICU census and many observable patient characteristics, and we don't find any correlation between census and acuity levels, insurance status, DRG code, and so on. So the concern here might be if, let's say when the ICU census gets really full, we stop admitting Medicaid patients or something like that, and Medicaid patients are a different type of patient than everyone else. If that kind of behavior was happening, this would create problems for our instrument. We don't see any correlation between the observable characteristics. Hopefully this tells us if there's some unobservables that it's also uncorrelated with that. And then lastly, and probably the most kind of important question, and one that's probably the hardest to test or impossible to test, is it possible that ICU census could directly impact mortality in other ways? So going back to this slide, is it possible that we want to try to limit all of the effect of ICU census on dead through this wait channel? So if it was possible that, for example, when the patient arrived to the ICU, if the ICU was really busy and that physician didn't pay any attention to the arriving patient, maybe that would impact the mortality rate, or so on. And in conversations with the clinical folks at Yale, we really actually think that's not much of a concern. So I can tell you at Yale, physicians are capped at how many patients they can see. It's 6 patients total at any given point that they can be sort of rounding with. And so, it's not one of these settings where sometimes they're going to be dealing with a huge number and other times they're going to be doing with less. I would also add that keep in mind that a patient is in the ICU on average for about 3 days. And so we don't expect a tremendous amount that's happening when they first arrive to impact their mortality, let's say 3 days later or a week later or so on. So we feel relatively comfortable. Of course, again, with an IV approach, you can't always prove this exclusion restriction, but what we feel relatively comfortable, and it has been used in other studies as an instrument. So the only kind of results I'll present for this are comparing the sort of naive probit model with the IV approach. And so I first want to talk on these coefficients on the left. So this is, again, just running a basic kind of binary outcome model, and we find exactly what we would have expected, which is patients who wait the longest for an ICU bed tend to be the least sick, and hence have a lower chance of dying. So if you just ran this model, you would really misestimate it. You actually get a negative sign for this wait. It's suggesting that waiting for a long time for a bed is a good thing, right? It lowers your chance of dying, but of course this is, again, because of this kind of selection issue. So when you run the same kind of model, but instead using census as an instrument, a couple things to point out. So first, the coefficient sign flips, which is what we would kind of expect and hope for. Unfortunately, we lose significance with this newer coefficient. This is not entirely surprising. I mean, instrumental variables tend to be less efficient estimators, so it's not hugely surprising. But so despite this not being statistically significant anymore, the way we would interpret this coefficient is each additional hour of waiting is associated with a 4 percentage point increase probability of death. So think of it as a patient who doesn't wait at all, let's say, has an 8% chance of dying. Patient who waits 1 hour has a 12% chance of dying, and so on. So we're talking about a huge, I mean, the magnitude of this is startling, I think, and actually very disconcerting as a potential patient, future patient myself. Hopefully not. And so this, again, we had about 2,000 patients in this sample, and this is the model that we really would like to test in other settings, because I think it's possible that things are going on at Yale that are impacting this. I think it would be much more compelling if we could find a similar magnitude coefficient at Ronald Reagan or at Mount Sinai. And so that's one area that we're actually very keen on exploring in next steps. And to put this graphically and to sort of illustrate what happens when you try to make a prediction far away from the mean, this graph shows the predicted mortality probability using this IV estimate. So these are marginal effects and the probability of death. And you can see, so close to the mean, which is, again, between 1 and 1.5 hours, we have relatively small error bars on our prediction. But if you're trying to make a mortality rate prediction for patients way out here, you're going to get these enormous estimates. So I think these results have to really be interpreted carefully and with a grain of salt. But I think it would be, if nonetheless, important to look at in other settings. And then the last kind of sort of robustness analysis that we did was actually looking, what if we break our patients into two types? So at Yale, the way that they categorize their patients are either acute or subacute. So acute patients are the sicker patients. They're the ones that have to be treated in the ICU. The subacute patients could actually be treated in the step-down unit. So these are patients who might require a little bit of extra monitoring or hemodialysis support or something. They don't necessarily need to be treated in the ICU, but they often are because the step-down unit is full. So the acute patients have a much higher baseline mortality rate, just raw numbers. And what we did is we reran the IV probit model using these as these two different subgroups. And again, that we lose significance, or this is, I say, borderline significant. I mean, it's if your significance cutoff is 10%, then it would be. But again, I'm a little bit reticent to make a claim here that this is significant. But if you look at the magnitude of these coefficients, what was surprising to us was that the subacute patients are actually more sensitive to waiting. And so the story here would be the acute patients are often given a bed first, so they're prioritized. But think of it as they're so sick that they're either going to die or not. That getting a bed an hour faster is not going to save their lives. Whereas the subacute patients are more on the fence. They're the ones that if they can get a bed in a quicker period of time, you can actually have an impact on their mortality. That's kind of, I think, the explanation for this. But again, I think we'd really like to try to test this in other hospital settings. Oh, question?
So when you, sorry, you probably said
No,
this
sure.
now, but when you say probability of death, this is a discharge from the unit, right?
This
It's
is-
not death in the future.
This is in hospital death. Yeah, during this particular hospital stay. So if they come back 30 days later, we don't, and they die, we don't include that, but it's this hospital stay. Yep. Yeah, so overall about, I forget the number, about 12 to 15% of our patients die. This is the breakdown for acute and subacute. So about 16% of our acute patients die in that hospital stay and 9% of the subacutes. So just to wrap up and talk about some future directions. So we do find consistent with some prior studies that higher ICU census does result in a shorter length of stay, and our coefficient is similar to other published studies. We also estimate the impact of medicine floor census on length of stay, and we find the reverse effect, that a higher census in the floor results in a longer ICU length of stay, again, because we speculate that the staff on the floor are delaying some of the transfers coming in from the ICU. However, when we separate this into the service and non-service components, we find that all of the effect occurs on the non-service time, which is, again, reassuring from a clinical perspective. And when we look at the nonlinear kind of decile model, we find that the effect really speeds up when the ICU is really full. So when we have 50 to 51 beds occupied, they do a really great job of getting patients out as needed and to free up that bed. And moreover, the floor census is associated with a longer length of stay, and we see this speed up effect occurring in a much faster, in a much earlier time period. So at the 50th percentile, we start to see this slowdown of transfers. And again, I think we talked about a number of explanations for this. I think part of it is the decentralization of the floor and different kind of decision makers allocating these beds. But nonetheless, I think this is something that the hospital could perhaps improve upon. And then we find using this instrumental variable model that each additional hour of waiting for an ICU bed increases your mortality by 4 percentage points. But again, this coefficient loses significance when we use census as an instrument. And in particular, the subacute patients are most sensitive to waiting, suggesting that ICU should really think about this trade-off in making triage decisions. So I think if there's one policy punchline from this, it's we shouldn't just allocate beds to the sickest patients. We should also think about who benefits the most from getting that bed. I think some ICUs are doing that, and they're looking at sort of who might benefit most in terms of mortality or other kind of clinical outcomes. But I think at least at Yale, that's not the model that they're using. So I'll just mention some limitations in our future work. So as I said, I think a major limitation is, of course, this is a single institution study. The upside is we have really granular data. It's often hard. This data is actually very, very difficult to come by. To get patient level timestamp data, I've been trying unsuccessfully so far for the last 6 months to get this data for UCLA, and I haven't yet been able to get it. So I'm optimistic. Hopefully we'll be able to get something. We also don't have other specific patient factors. So as we talked about previously, I think looking at billing codes as possible explanations would be really interesting. Other outcomes, so I mentioned catheter-related infections. Many hospitals are now keeping track of that because of how reimbursement is occurring. So if we could look at the impact of, let's say, this non-service time on catheter-related infections, I think that would be really interesting. We also don't have physician fixed effects. So it might be that some physicians are just really good at getting their patients out when they need to, and others are not so good. Ideally, we'd like to examine that in future work. Same thing with staffing levels. In our setting, by and large, they have relatively constant nurse staffing levels regardless of how many patients are there. But of course, there might be some day-to-day or hour-to-hour variation. And as I mentioned, we're working on, my colleague who's now at Mount Sinai is working on getting data, similar data to this at her hospital, which is a very different urban hospital in New York City. And then we've actually also developed a queuing simulation model to look at the question of how many ICU and how many step-down beds should we have if our overall goal is, let's say, minimizing mortality or minimizing readmission risk or minimizing wait times even. And so we're using the results for this empirical model, in particular the non-service component. As many of you know, in a queuing type framework, we often treat service time as this kind of exogenous variable, like it's exponentially distributed with a mean of 3 days. It turns out, as we've shown, the service time actually it's state dependent. So the non-service time depends on how many patients are actually in the unit. And so if we're building an accurate, I think, a realistic simulation model, we wanted to take into account the fact that physicians are speeding up care as the census gets bigger. So that's some ongoing work that we're interested in. But I'm happy we have a few minutes for questions. To stick around. Yes, question.
Have you ever taken into account the impact of family advocacy on the wait time and the non-service time for the ICU or exiting?
So,
Can you restate?
Yeah, sure. So the question was if I've looked at family advocacy on the impact of either wait times or service or non-service times. No, I think that's a great question. I haven't looked at that. And, you know, of course, I think part of this analysis is limited by the data that we can get. And if that's something that the hospital is both keeping track of and potentially kind of collating with these other things, I think that, you know, the census level, I'm sure, also impacts that, right? You got to imagine that as the ICU gets busier, they maybe have less time for things like family advocacy. No, I think that's a huge, I mean, when I think about kind of what excites me and interests me about these future projects, I think the question of both, you know, end-of-life care and how we make these decisions about the goals of care are really important. And what I don't want to see is patients' goals of care being affected by how busy the ICU is. That should not impact what a patient decides, especially at end-of-life care. It should depend on a lot of these other factors. You know, I think in the data, of course, we observe that it does depend on things like census levels. But yeah, I think that's a great comment. Inez?
So Elisa, this is really fascinating, and thanks for coming here. It shows how an empirical model can inform translational science work. So it's just really, really appreciate the work. And I was wondering if you could, I'd be triggered by what Joe said and the person who was next to him about, wouldn't you have the variables though for the medicine departments, and why you didn't include that, like where the destination departments were for each patient?
So
that be included in the model?
Yeah, so the question was about the destination of where the patient goes after they leave. So I believe for the individual patient, we know like what unit they end up on. But unfortunately, I can't observe in the data, let's say, how many other patients are in the cardiac unit at the time that patient is discharged. The hospital doesn't report that. The hospital reports ICU. The three numbers we have are like ICU census, floor census, and hospital census.
Right. No, keep the total, but have a categorical for those, so it would soak up.
For where?
Yeah,
we could. I think look at that. I think so.
Get rid of some unobserved heterogeneity
in where,
for each,
right? Yeah. So for example, maybe oncology is just really bad at getting their patients in or something. Yeah, that would be interesting. We could definitely, I think, look at that. Yeah, that's a good suggestion. Yes, and then.
I was wondering if you could speculate a little bit, since you mentioned nurse staffing. How is this going to be different in California, given that Connecticut, I believe their nurse staffing law isn't as restrictive and it's like determined by a committee, whereas California, it's dictated in statute that you have a certain ratio of nurses and there's less flexibility.
So, I mean, I'm not super familiar with state-by-state laws on this, but as far as I know, I believe Connecticut has similar, at least the numbers I've seen for the ICU versus the step-down, those are pretty much given over this time horizon. Like the nursing ratios in the ICU are about 2 to 1, and in the step-down unit are about 3 to 1 patient-to-nurse ratios, which are vastly different than the floor. I think that, looking at, of course, if there's changes in legislation or something like that would, of course, be really interesting. But as far as I know, I haven't, during this time frame, seen any changes in nursing staffing. Yeah, question?
I think Dr. Ponce's point, what I would be most interested in is the mortality estimation. I think that stratified by acuity is like right on, but you're, like you said, the very acute patients are problematic subgroup to deal with anyway, and your outcome is mortality because they just might not be savable. but I think if you look at primary service, like a cardiac patient versus a GI, you might find some more homogeneous groups that you'd be able to make a nicer comparison between. Like if a GI patient comes in, and you can put a cardiac patient, it's pretty obvious why they're being sent to this unit. So I think that
Yeah.
an interesting way of breaking out your mortality.
Okay, so the comment was about sort of separating patients by, in addition to acuity level, by kind of clinical subfield. I should point out, and I didn't mention this, it's in the paper though. We do have primary DRG code, which does implicitly capture kind of these broad level characteristics. So if it was liver versus cardiac versus so on. What's interesting is when we run when we look at all of these as different dummies, the only one that was very significant for length of stay was transplant, which is maybe not surprising, that patients who get, and they code it as just transplant, it's not heart or liver or heart, but patients who are transplant patients who end up in the ICU stay something like 200% longer than everyone else. Because they're I think, they're in there for a while and they're recovering and so on. No other DRG code was significant for length of stay, at least in the ICU. Which
Makes sense.
Yeah, so we are trying to capture some of this, but I think the point about which unit they go to in the hospital, that part of that is captured in the DRG analysis, but there could be other unit kind of effects.
Yeah, other type of.
Yeah, or maybe just geography. So this is a I think about a 12-floor pavilion, and the ICU is on 2 floors. So you could even imagine if you're close by, you run into your physician in the elevator and you say, "Hey, do you guys have a bed available? I have a patient coming out." I think a lot of, we forget that a lot of that is going to drive how some of these transfers occur. Any other questions? So, well, thank you very much. You guys were terrific. Thank you.